that's where we started to investigate, and we wanted to develop an implant that would work for us because we have our own dental lab. And this is our company is called Oral Iceberg, and we gave the name Oral Iceberg because it's the structure of zirconia. It reminds of powerful structures such as the icebergs, and for us these are the base of the iceberg. These people are not visible, but they are the ones that are making the structure of the iceberg, and it's good that we have them on board. We work together in grand years. I've been 3 years now in California, and every time I get a chance to go to Barcelona, I enjoy doing surgeries with them. We started developing the system about 8 years ago, and the first implants that we used were prototypes, and they were very similar to conventional titanium implants. And when we mean conventional, we mean implants with flat platform, implants that did not mimic the tooth structure. And we are going to talk about the osseointegration of the implants. The implants are acid etch with good treatment. The first important study histologically that we did was with the University of Minnesota. We placed some implants in the hip of sheep, and we retrieved them 3 months after, and results showed that there was a bone-to-implant contact of 78%. We acid etch all the implant, so not just the surface of the threaded portion, but also the transgingival portion and the abutment portion. So when we are screwing the implants, especially in flapless techniques, we do not give too much importance whether the threaded portion is all the way into the bone or half of a thread is out of the bone, because the whole implant has the same surface treatment. So many times we do immediate extractions. 75% of our treatments are immediate placement after extraction, and sometimes we can have bone contact in this area, and because of the anatomy of the ridge, maybe the bone in other areas are lower, so we are happy to have this type of surface. And when we did this histology, it was only hard tissue. We were not able to see how the gingiva and soft tissues were in contact with this surface. And when we zoom in to the different areas of the implant, this is the area where the implant starts to be shoulder for the crown, so you can see that the bone contacts in very high bond with the implant. And this is the surface of the implant, this is the bone. And when people ask us if zirconia implants integrate, we tell them, in our opinion, they integrate much stronger than conventional titanium implants. And the reason is because in titanium implants, the oxidized layer is right at the connection between the bone and the implant, and you don't get to see it microscopically. You would have to go under an electron microscope. Whereas this type of implants, the whole body is made of an oxide. So the same characteristics is all along the surface. We don't have weaker areas of oxidation titanium. This implant is all the way inside with the same structure. So it's a much more stable material than titanium. And because animals are different than humans, and we didn't have the soft tissue contact with the implant, we decided to do a human histology. This is a patient with low economic income, and he could not afford the big prosthetic treatment that he was in need, and he was open to have several implants placed in his mouth for full mouth rehabilitation, and one of the implants to be removed for inspection of the bone and soft tissue. So he went to the Social Security in Spain, and he got all the teeth removed, and once the alveolar ridge was pretty much flat, we placed the implants, and 3 months after we came back and we were able to refine the not just the bone but the gum around the implant. This is the implant. It's a CeraRoot 12. It's an implant designed for upper laterals or lower incisors. This implant was placed in the area of the upper left canine, and we decided that the most important area that we wanted to see was right in the middle of the implant. So we gave instructions to do most of the histological analysis at the biggest diameter area, and especially at the shoulder level, so we could see what was underneath the gum. And this is the histology. The zoom of the histology was done in 2 parts. So this is one slide and the other slide, but this is how the two histological views under the microscope look like. And when we zoom inside the gum, this is what we find. This is the circular epithelium. It's an area that it's non-attached. It's not attached to the natural teeth. It's mobile, and then we have. So this is more or less the circular epithelium. It's about the first millimeter. So this is a tooth preparation of for a veneer, and this is much more subgingival than normal. This is an image taken from the internet, and I was just showing you the first millimeter where we would be. Then we have the junctional epithelium, the area that it's free and not attached. It's keratinized, and the rest of the gum up to the bone is non-keratinized. Then we have the connective tissue area, and this is the most strong bone and the most important area of the implant in connection with the gum. This is where the gum will maintain the implant in good health. And of course, deeper we have the bone. And then when we zoom this connective tissue, this is what it looks like. The surface of the implant is rough enough so that the fibers get in well and very strong bond. These implants, even if they are completely straight without a shoulder, they are not able to be probed more than 2 millimeters. And sometimes natural teeth and very healthy periodontium prove deeper than what these implants prove. And we think it's because, first of all, because it's one piece, so there's no subgingival connections. This is the most important factor. And the second factor is because it's an acid-etched surface where the fibers can get good adherence. This is a titanium implant. In the beginning, titanium implants used to be placed only the surface treatment area used to be placed inside the bone, and then there was always what we called a transgingival portion, and this transgingival portion gave health to the gum because the cementation, if this was a cemented prosthesis, and this is what it is, the cement would not be placed too close to the bone. So these implants were the most stable type of implants, and the only inconvenience that they have is that in very thin gums, the grayness of the implant would show through, or if there was a recession, patients would complain that part of the transgingival portion was visible. Because of that, the industry took the margin of the titanium implants to the bone level, so any resorption that there would be, it would not be 1 year post-op, it would be maybe 5 to 10 years post-op. And this is not good because all the systems, when I say all, it means all, the systems have microleakage. Microleakage means that bacteria grow inside these connections. And I don't know how many of you have unscrewed titanium implant components, but when you unscrew them and they stay on top of the table, they produce a very strong smell, and this is all the time inside the mouth. And no matter how well you brush your implants, even if you're a dentist, they will smell too. So bad smelling means bacteria, and for us that we have been working with titanium implants, my father started with implants maybe 35, 40 years ago. We've seen all kinds of diseases with titanium implants, and the gum response was always much better in implants that were gum level or even supragingival. So patients that were complaining that the metal was visible were the patients that had the better gum color. And the deeper the implants were to become more aesthetic, the more redness and the more they tended to bleed. So most of the implants that we do immediately come out like this. So we can see the actual, not just abutment, but the actual shoulder of the implant. And the crown should not start deeper than the first millimeter of the sulcus. So this is the shoulder of the implant, and this implant will be always healthy because the distance from the margin to the bone is very important. If we put the margin deeper, then we will have swollen, and we will have not healthy looking gums. This is the connection where the cement is, and you can see this area is deeper, and you can see that the reaction of the gum seems to be much more strong the deeper the implant is. So this area looks healthy, this area doesn't look, and it's not even close to the bone level. And when we look in natural dentition, we see that healthy gingiva does not have inflammatory cells, and the more disease that we see, the bigger the problem and the more reactive, and the more red we see the gums. This is the dentin, this is the cement of the tooth, this is the enamel portion of a natural tooth, and this is how the gum should look like when it's healthy, and this is the gum, how it looks like when there is no crown, because this implant doesn't have a crown, or when the crown starts not deeper than the first millimeter of sulcus. So the conclusion of this slide is with zirconia implants, don't go deeper than the first millimeter of sulcus. This is a zooming of the junctional epithelium, and this is the bone of the tooth. This is the cementum of the root, and this is where the periodontal ligament would start. And we see that the inflammatory cells are almost non-present. Yes?
Have you seen a side like that with an interface between the crown and the zirconia implant with some kind of cement?
We have seen.
What does the cement produce?
Can you repeat the question?
Yes, he was asking if we have seen slides or histologies that show reaction when the cement is deep. And I have seen some histologies, I have not posted them, but for me the most visual thing to see when an implant is too deep is that they tend to suppurate. Implants that are the cement, when the cement is deep, there creates a fistula. And I will show you some cases, not histologies, I will show you some cases when the implants are placed too deep and cemented too deep, what type of problems do we have? When we zoom the other part of the implant, this is what we see. It's a very healthy gum. When we zoom even more, this is supposed to be free gingival area. So when we look at titanium, yes?
Are you going to show the histology with the crown on the implant?
No. When we see histologies of titanium implants, because the connection, the subgingival connection is too deep, we see that the gum does not stay in contact with the implant. It's a very normal type of histology. So it's very rare, at least from the conversation that I had with biologists that did these preparations. He told me that when we were doing the histology with soft tissue, he told me, when you will do the trephine, you will do mobility on the gum, and the gum will not be attached to the implant. So if you want to see attachment, I'm sorry, but probably you will not get to see what type of connection you have, the implant has with the gum. And when he saw the histology, he was extremely surprised, because he did not receive specimens with this type of soft tissue connection to the implant. And when we zoom even more, this is the type of contact that we have with the implant. And we think it's a rough enough surface to maintain the gum bond with the implant. And then when we look at bone contact with the implant, this implant was placed flapless, so you can see the different levels in the maxilla that we have. So even though the threaded portion is completely inside of the bone, we have areas with less amount of bone and areas with more bone. So that's why it's important to to be sure that your crown will not be too deep. When we zoom in the bony area, this is the contact that we see. This is new bone formation, and this is the connective tissue, and we can see that there is no inflammatory reaction. And this is another area, the threaded portion area, deeper down into the bone. And when we zoom in this area, we can see the line where we produced the osteotomy. So this is where the drill came in to the socket, and the implant was not in contact during the healing time. The implant, many parts of the implant were not in contact with healed bone or non-formed bone, and we can see that the gap where the bone used to be and the implant, the gap is completely being filled with new bone. And when we look at more areas of the implant, and we see that there is a big marrow space, but when we zoom in, we can see that there is actual bone formation all along the implant, not just the threaded portion, but the transgingival portion of the implant. When we look at another area, we can see the new bone formation on the implant. And new bone formation in the threaded portion, so we can see that areas that will receive load in the future are starting to be in contact with new bone. So even though this implant has not been loaded, we can see that the bone apposition is being done in between threads also. So there is a very nice connection in between threads. And not just inside the thread, but also covering all the areas. We think that the thread formation, the shape of the thread, is not really important in terms of osseointegration. And this is new bone formation, and this is mature bone. The first prototypes that were similar to the final design, scalloped, that were similar to natural dentition, were machined. The whole threaded area was machined, was not acid etched. The abutment was machined, and then the transgingival portion of the implant was polished. So it would be extremely polished. It would be glass. We did this thinking that it would be much better for the plaque control and for the stability of the soft tissues. And we have seen over the years that the probing on these implants, although they are healthy, the probing on these implants is much deeper because the gum doesn't have the fibers of the gum. We think that the fibers of the gum doesn't have enough roughness to adhere to the implants. So this area was polished on purpose, but over time we have seen that gum does not grow on top of the polished surface as they do with a roughened surface. this implant was placed immediately after the extraction. This implant was placed flapless. And the type of surface that we use now for the last 8-9 years is acid etch surface. And when the implant has a rough surface and the blood gets in contact with the rough surface, and you try to clean this area with water spray, it takes time for the blood to disappear from the white structure. When we have a machined surface or sandblasted surface, because we've done several different surfaces, when we have machined or sandblasted, the blood disappears from the implant extremely fast. So this is for us, this has been worked and been proved to be the most fast and the most fast in terms of osseointegration and the more stronger bond to the bone to the implant. And we call it ice surface because when we look at area that has snow on the top, the crystals that the ice crystals produce are similar to the ones that we see on under the electron microscope. What advantages does the implant have when we do no flap? The stability of the tissue is perfect. The gum does not modify. We have the reference of the gum, so we don't have to think where the bone is. We just want to leave the margin gum level. And this is good because we don't have to predict where the healing of the gum will be. And this is 4 months post-op. Very nice contour, flapless implant, immediate placement after extraction. And when we compare nowadays two-piece implant, this is the type of connection that we see when it's screwed. This is for a titanium implant, so this is the type of connection that we see. It's very deep and too weak. One-piece implant. Why one piece? Because we want to restore all the implant always in the first millimeter of sulcus and not have prosthetic connections under the gum. So if this was a patient that came into our office and we looked into the mouth and this was a piece of a root of a tooth, and the patient would ask, doctor, I want you to restore this root. We would tell the patient that you cannot ask this because I cannot restore such a deep root. But with implants, with titanium implants, we do this. We do this only because we want to hide the metal grayness. So many times we have to put the implants deep and palatally so that the patient does not complain about the color. So we think that this is much more conservative, and this does not produce smell on the implant. So once you bond the crown on this type of implants, patients do not complain, of course, of metal taste, but even more important, they do not feel strong smell coming from their mouth. So this is the type of situation that we always want to see. Sometimes we have the implant deeper because we did a much stronger regeneration, and the implant healed much more nicely than we were hoping or thinking, and sometimes we are deeper than the first millimeter, but try to have all your surgeries as much close to the gum line as possible. So this is a patient that came with an infection socket, and when the infection is acute, we don't want to place the implant. We prescribe antibiotic, and the patient comes back 15 days after, and then we clean the socket. If all the buccal plate and all the bone, mesial and distal, is preserved, we do the surgery through the socket. We don't open the gum. We place the implant. This is an implant that is specifically designed for premolars. The head of the implant is ovoid. It's not cylindrical. We will see after the advantages of doing this type of emergence profile. And because we do a flapless technique, the gum, we know that it will be very stable. So when patients are from far away, we take impressions the same day. We use impression coping that is made of zirconia. The impression coping has the same exact shape on the margin of the implant. We most of the times we use sticky wax inside the coping, and the coping is retentive enough to stay in place. And if the gum is pushing the implant away, sometimes we put a very little amount of temporary cement. Not a lot, because we don't want cement to flow inside the extraction site, so just enough so that there's stability. And then the coping stays inside the impression, because it's a pickup impression. And when we send the coping to inside the impression to the lab, they work with the lab analog, and they can manufacture the crown. And finally, 4 months post-op, we can cement the final all-ceramic crown. And when we look at emergence profile, we can see that there are millions of different designs, and we do not agree in implants that are so deep and, of course, producing microleakage and inflammation of the area. This is not a natural emergence profile, because food tends to get stuck in these areas. And when we look at zirconia implants with emergence profile similar to a natural molar, the type of soft tissue volume that we see is almost as natural as the natural dentition. And because the implant is so big, we don't see the concavities on the buccal plate as you tend to see with titanium implants over time. This patient is a maintained perio patient and has most of the roots exposed. And when we see this type of distance, this is very scalloped gingiva. There is a big distance. So when we place implants, we don't want to place implants close to the bone or where the bone is. We want to place implants that are not too much subgingivally, especially interproximally, and ideally we want this shoulder at the gum line, but sometimes the interproximal distance is already long enough, so we don't want to put the implant deeper. This is day of surgery, and this is 8 years post-op, and we can see that the implant is a little bit more exposed, but patients normally do not complain of this type of situation. They complain that the roots of their teeth are yellow, and the more they brush, the more yellow they become. And the advantages of doing one-piece implants is that we don't have subgingival connection. There is less bacteria. There is everything stays on the prosthetic connection. We don't have ever any screw loosening, so patients do not come with crown mobility. And the color of the gum is always similar to the natural teeth, and it doesn't matter how much thickness of gum we have in front of the implant. Zirconium oxide. The implants are made of zirconium oxide. Zirconium, we saw yesterday, the pure element, it's metal rod, and it has double mass than the titanium element. But we, the industry is able to extract the element of the most common mineral that the zirconium is present is called zircon or zirconium silicate. This is one of the most current minerals on the crust of the earth. And another mineral where the zirconium is present is called badellate, but this is more rare mineral. And one of the bigger providers of this mineral is comes from Australia sand beach. So they extract the zirconium element from the mineral, and they can obtain metal rod, or they can obtain the oxidized molecule of the implant. And it goes through a chlorination process, and it goes also through a precipitation process in order to obtain the zirconium oxide. In order to see how much these implants are strong, we put the implants under the test. This is saline and the same temperature that we would have in the oral cavity. We put the implants at a 30-degree inclination, and also 3 threads of bone loss. So all this portion apically is placed into the resin material, and the rest of the implant is loaded with the machine. When the machine does static pressure on the implant, the range of strength is between 22 and 3,000 newtons. This is 5 times stronger than a natural central incisor. And when the machine is doing impacts, impacts trying to imitate the human masticatory forces, 2 million impacts is more or less about 5 years of human function. And when the machine is producing all the time forces between 1800 and 2200, the implant is capable of withstanding this amount of forces all the time, not just sometimes are stronger or sometimes are weaker. The machine is producing this amount of strength, and after 2 million impacts, the implants are still completely strong with the same strength. So a solid block of zirconia is not the same as something hollow. So people that have had very bad experiences with zirconia abutments cannot compare this type of design to a complete solid cylinder of zirconium oxide without any connection. The system has different implant designs in order to identify which position is better for each design. So the yellow implant, it's called CeraRoot 12, is designed for upper lateral incisors and lower incisors. And this is a type of situation. This is a hopeless tooth with an apical lesion. We try to do, of course, no retreatments of root canals, and patients that are not sure what type of treatment is better, if root canal or implant. We always tell them that implant does not absorb any type of liquid or bacteria, and the implant will not suffer damage over time, whereas the tooth, for sure, due to the age of the patient, for sure, the tooth will be extracted soon or later. And in titanium implants, normally the implant is placed deep and palatally. So in general, where the tooth is extracted, this is where the implant could normally be screwed in. But when we do one-piece implants, the direction of the implant has to be in the anterior zone, has to be at the incisal edge direction. So every time we are drilling, we have the drill coming out at the same direction as the incisal edge. This is the extraction, and we clean the extraction socket. We make sure that there is no soft tissue inside, and this is an amount of bone extremely important for us. This gives us enough confidence to do the implant the same day of the extraction. And because it's a one-piece implant, it needs a straight. We have to make the drilling more buccally than where the tooth used to be. And this is where the implant goes. We have probably more than 100 cases of implants much closer to natural tooth than half a millimeter. So for us, it's not important if the implant is almost touching a natural tooth supragingivally. It's important that the implant inside the bone is at least almost a millimeter away from the periodontal ligament. This is how the implant is placed inside the extraction, and this is the type of anatomy that we would like to see. Because the tooth was placed palatally, the shape of the bone is not scalloped, so this bone structure is not the type of structure that we would see in a conventional extraction when the tooth is well aligned. So the most important decision when placing an implant is the interproximal implant level of the shoulder should not get closer to the bone more than 2 millimeters. So when we raise a flap, we don't want this margin to be closer than 2 millimeters off to the bone. And when we do flapless technique, we leave this shoulder at the gum level. We graft. We have the most experience using bovine bone, but we also have very good results with artificial TCP, and we have very little experience using cadaver bone. This is the type of flap that we do when we have a defect. We don't make two incisions. We make an incision first distal to the lesion, and then we open the gum mesially. And if we have enough visibility, just by doing one vertical incision, we have plenty. We like to work with Gore-Tex sutures. These sutures can stay in the mouth for a long time. They can stay 1 or 2 months, and they do not produce any type of swelling. And this is 4 months post-op. look at the distance that we have from the margin of the implant to the bone, probably about 3 millimeters. And when the patient comes 4 months post-op, the margin of the implant is gum level. Distally, the margin of the implant is a little bit supragingival, but because this is the distal portion of the implant, many times we do the crown sitting on this margin, so we don't prep this margin, we make the crown sitting, and over time the crown protects the gum due to masticatory forces, and we can see many times the gum creeping and covering parts of implant that was visible. When we take impressions, in a case like this, in the anterior zone, we try to stay away of lasers or electrosurge because they tend to produce more recession, and we use either the coping or sometimes very thin retraction cord, enough so that we have a visibility of the whole margin. Palatally, if we have a growth, because the palatal gum is much more thickness, we don't care of removing with laser or electrosurge. In the anterior zone, we like to use Emax crowns. It's a much more translucent material than zirconia crowns. This is day of cementation. We saw presentations yesterday and 2 days ago how important is to leave space for the gum to fill out. So don't create crowns that are too square shape on the apical portion, because you have to have confidence that the papilla will improve. And this is what we see 8 months post-op. We see that the gum level, the gum is filling up the space.
Wow.
And the grafted area, we can see that there is some bone apposition on the fenestration that we had. So before and after. This is the implant designed for small or normal central incisors. This is the type of implant used in 90% of the cases in the central incisor area. It's 4.1 at the apex, 4.8 at the coronal thread, 6 millimeter at the shoulder level. When we have to extract a tooth like this, and we have this type of scallop shape on the gum, it's root fracture. It's very difficult to know how deep do we place the implant. So on the buccal of the tooth, probably the bone is about 2 millimeters subgingivally, but interproximally the bone is not that far. So we want to place the implant in this area. We know that if we put this implant deeper, we will have problems interproximally. When we did the first prototypes, the implants had a complete flat platform. So when we were good at this level, we were too deep interproximally because the platform was flat. With this type of design, in immediate placements, the restoration is much more soft tissue friendly. Anywhere we have space, we like to graft, so we fill up the extraction socket with bone particles, and because the patient is from far away, we like to take impressions the same day, even if the gum is not covering. We like to take impressions, so we have future margin in case the implant comes with the gum covered. The copings come in different colors. So each implant has 3 different colors, white for Hollywood, A1 and A2. This is the lab analog. So as long as you don't create any modification on the implant, the coping sits perfectly on the implant. And in anterior zone, if patients want to have maximum aesthetics, they always go without temporaries. So patients that complain with Essex, we tell them, and they want a temporary crown on the implant, we tell them that yes, you will be more comfortable, but you will have less gum if you have a crown placed on the implant since the day of implant placement. So if they want maximum aesthetics, they have to stay without crown. And when they stay without crown, gum creeps down. When we put a temporary sitting on the margin of the implant, the gum doesn't go anywhere. The gum stays at the temporary crown level. Yes?
Sorry that I interrupt you. I have a question. When you make the impression from the implant,
Yes.
with your pre-conventional industrial cups,
Yep.
how does the cup fit on the abutment?
This is
Because you have not a click mechanism?
exactly. This is a coping made of zirconia. It's not plastic. It's made of zirconia, so it doesn't produce a click.
Okay.
It just sits on the implant, and we, if we don't see the margin of the implant, we have to take X-ray. We have to take X-ray. But every time the margin of the implant is fully visible, so you get to see the margin through the gum, the crown always sits on the implant because the implant is scalloped, and the crown cannot sit in a left or right. It always, when you press down, the crown always sits in the final spot. So every time you place either sticky wax or cement, the coping can only go in one direction.
Even when you make the impression and you have the impression material and the spoon, you do not see the, you have not, do you have a control that it fitted on the abutment?
Because we don't take impressions if we don't see the margin. So when we put the coping, we have to see 360, but subgingivally. Of course, it's not gum level; it's subgingivally. If it's 360 visible but deep into the gum, it's easy because it can only go in one way. But when the gum is covering the shoulder, if it's covering, what we do is we put temporary cement. We push down. This is 4 months post-op, not in surgery time. 4 months post-op, we put temporary cement. We push down the gum. We don't care how the crown is connected to the implant, and we tell the patient to come 2 weeks post-op, 2 weeks post-visit, and when we take out the crown, sometimes there is no gum, and sometimes there is a very thin layer between the coping and the implant. And that thin layer we remove with laser or electrosurgery, but just the layer on the shoulder, not in the sulcus, not deep. And when we take that layer, then because it's clean, then the coping sits completely straight down.
How many months do you leave it?
The coping?
No,
In immediate extractions, 4 months. At 4 months.
So the patient go without any tooth for 4 months?
Yes. If they want aesthetics, yes.
Okay.
If they don't care about aesthetics, then you can do anything. You can put any type of temporary. If the patient wants crown, if the patient wants crown, for sure, we don't do the temporary crown up to here. Never. So if the patient wants crown, we put the crown much lower. So we don't know where the implant will heal, but the temporary crown is far away from the margin. So sometimes the patient leaves the office with the temporary crown not touching the gum. So in no case we put the temporary crown to the gum, to the shoulder during healing time. And this is just with bone graft, no gum graft. So the gum level is actually lower than the natural dentition. When we see, if we place any type of temporary solution, with the gum never comes down. Plaque retention and gum growth is not compatible. Because we took impressions on the day of surgery, we know where the margin of the implant is. Even if we don't see it, we took impressions, because in the beginning we didn't know where the gum would stay. So because we took impressions, we already know. So sometimes patients come for cementation, and we do temporary cement on the crown, and if the patient can stay without anesthesia, pressing the gum, we don't place anesthesia, but sometimes you have to do minor anesthesia. The gum is still not completely shaped. It has not filled the spaces. In the front area, we like to use Emax crowns. And 1 month post-op, we still see that the gum is still not completely shaped. And 7 months post-op, the patient comes with chipping on the Emax crown. She fainted, and she fell down, and she broke this part, and also she lost the sensitivity on this tooth, so she had to have root canal on this tooth. But I want you to see the difference between 1 month. The gum is completely round, it's not defined, but when we look 7 months after, we see that the papilla is as normal as a natural tooth. So we prep again the whole crown, and this is the type of abutment. Sometimes we don't prep all the way to the abutment. Sometimes we prep the old crown, and we make a new crown on top of the part of the old crown. So the adhesion nowadays is so strong that you can cement in prepped areas of older crowns. And this is the tissue that we have, and this is the new final crown. So. Yes.
Karim, here's a microphone.
Now, with this previous case, the amount of gum growth, of course, is fantastic. So what would you do to trim this gum off?
Yes, exactly. Yes, good question. I didn't remember to tell you. If patient comes like this and we didn't take impressions, we cannot use retraction cord. If we use retraction cord, we are doing a huge damage, because this does not prove. When you try to put, when the gum has creeped down like this, and you put the cord, and you try to go deeper than the shoulder level, you are creating damage, and you feel it, because when you are pushing, you are creating damage. So we don't want to do this. What we do is, because we want to preserve as much as possible the gum, we bring the coping. So we put some anesthesia on the gum, we put cement on the coping, and we push as strong as possible the coping, pressing the gum. The patient goes home with ischemic reaction on the gum. We do composite around the coping, and we don't care where the gum is pressed underneath the coping, because the patient will come 2-3 weeks later. So we have control of the cement that it's subgingival. So 2 weeks after, we take down the coping, and we have access to the margin, because the ischemic reaction has remodeled the gum. It has not make a recession, it just has pushed the gums sideways and little apically. So in the front area, at the moment that you use laser or electrosurge, your gum goes up, because it's extremely difficult to predict where your gum will be. So when your gum is 2 millimeters below the natural dentition, you can do anything you want, because you are safe far away. But when you are at the same level of the natural teeth, and the patient has a high smile line, if you use something to remove that gum, you have a problem. Yes.
Now, while you're placing the implant, you have interproximal shape, lingual or buccal shape.
Yep.
How do you place it so it screws in?
Exactly. Yes. Let me show you the extraction socket. This is the extraction socket.
Okay.
And when you are getting close, when this margin is getting close to the final position, final means 2 millimeters. When we are 2 millimeters far away, we know that the implant has to go in every time 180 degrees. It cannot go in 90 degrees, because it goes 90 degrees, you are completely in the wrong direction. So when you're getting close to the final position, 2 millimeters before, you have to start seeing that that every time you will go in, you will have to go in 180s. So if at some point your torque starts to go high, and when we mean high, means not more than 40 newtons with this central incisor. So when we are close to 35 and we are doing 180, we have to stop and check where are we. Can we go deeper because we are still too much supragingival? Yes. Do I have room for the torque? Yes. I do 180 more. Sometimes waiting gives you more elasticity on the bone, and you are able to place the implant once again 180. Of course, in the front this is important. In the back, when we have implants that are not aligned, sometimes you have an implant with not so much torque, and you cannot go deeper because you have the nerve, and you cannot unscrew, because if you unscrew you lose stability. So sometimes where the implant stops, it's where we restore, and we don't care of the margin because we make a new preparation. So in the front, if you have drilled through the incisal edge and your direction is correct, and it's an immediate extraction, it's not difficult, it's time to go 180. Yes?
Excuse me. What kind of template the patient get from you when you are working with the coping from the beginning on? When you finish surgery, he need a template during the healing period.
He goes with Essex. Essex appliance is the same as the Invisalign tray, and inside the tray we put a composite veneer. So when the patient wears the Essex or the Invisalign tray, on the missing tooth there is a veneer of composite. If the veneer is retentive, it will not move, it will not go sideways. But if it's not retentive, sometimes what we do is we do 2 holes on the Essex, and we make a veneer on the inside and we make a veneer on the outside, connected with the 2 holes in the plastic. So the patient wears normally the ASICs with the inside veneer of composite. And this veneer is very easy. With a flowable composite, even our assistants do it. They just put it horizontal, so they put the tooth structure horizontal. The plastic is at the same parallel to the floor, so it doesn't keep dropping down. So you put this, you do one layer, you cure, you do another layer, and so on. Enough so that between the veneer and the abutment there is plenty of space. Now we will go faster. If someone faster, we don't have too much time. But if someone wants to ask a question, please do. So this is the big central incisor implant. It's a huge central. It's the stronger. It's the mechanical testing that I was showing you before. So patients that are able to fracture their own teeth in half, not just horizontally but also vertically. Patients that are this much destroyers, if you don't use a powerful implant, they will fracture. They will fracture. If you put the crown in occlusion, they will fracture narrow implants. So patients that fracture their own teeth, please use the biggest implants that you can. This is the day of surgery, and this patient had lesions underneath the, some decays underneath the gum. So we agreed with the patient that we would do gingivectomy on all the teeth. He could afford 1 inch of gingivectomy. So we told the patient we will do gingivectomy once the implant is healed. So we decided to put the implant deeper because the bone also was far away. You will see on the X-ray that it's a patient with a flat bone. It's not a scalloped bone. Every time we have bone buccally and all the walls are present, we put the implant without opening a flap. And this is 1 week post-op. Patients do not believe that they had a surgery 1 week after, and normally they don't take any type of anti-inflammatory because comparing this type of surgery to a fracture of a natural tooth, you can imagine the difference. 1 week post-op, and it's time to make the crown. So this type of patient, we make huge gingivectomy with laser. We don't care about the gum because we will have to make recessions in all the teeth in order to treat the decays. And this looks like burnt gum, but it's a projector. There's a little bit of ischemic, but not that much. And we use this type of zirconia crowns with porcelain, with some porcelain. But even if there is chipping, it will even look more natural. It will look like it's a Braxer, so no problem. And this is the level of the implant. This is the shoulder of the implant, and we make the gingivectomy, and then we go ahead and do the gingivectomy in all the teeth in order to treat the lesions. And this is 3-4 weeks after how the thing has healed. And look at the height of this gum. This patient has diastemas between teeth, and this gum is probably more than 10 millimeters away from the bone. And this is, we're talking 4 or 5 months post-op. So no contact point, diastema, and we can see very nice stability of the bone and a strong crown. It looks like the implant has already included the crown. premolar, the premolars are ovoid shape. We designed ovoid shape because premolars are ovoid, and when you are cementing in the premolar area, converting something cylindrical to something ovoid, the emergence profile is very strange. So the more deep you go with the implant, the more natural the premolar crown looks like. So with cylindrical implants, we have to go deep to have a good emergence profile. But with ovoid implants like this, the crown starts at the crest, buccal crest, and the lingual crest. So we are not creating mushroom crowns. And this is soft tissue, and this is soft tissue friendly because you are able to clean the cement lingually, buccally. When you are doing this type of implants, it's extremely difficult to clean cement that is towards the middle of the crest. This is another zirconia implant. This patient has very, very little amount of keratinized tissue. It's extremely important to have 1 or 2 millimeters of keratinized tissue. So if this gum was covering this margin, do not use electrosurge or laser to remove keratinized tissue. If you have this type of thin tissue, use a coping or use retraction cord. If you laser this and you have non-keratinized tissue, you will have not good long-term stability, and the tissue will keep receding on the implant, just the same way it does on natural teeth. So this is day of placement. We don't want the implant deeper. It's a patient that doesn't care about aesthetics. So if the implant is visible 4 months post-op, it will not create any problem. So this is 4 months post-op. Yes?
Is it okay to just submit the coping on the day of the surgery and let them walk out like that?
Coping, it's too much occlusal surface for the patient to bite on. So we prefer to go with the smallest portion of implant coming out through the gum. So in case the patient doesn't wear the Essex for chewing, there will be less surface contact for the patient to bite on. So we prefer on the day of surgery, Essex and no coping on the implant. That's what you asked, right?
But you could shave the coping down so that it doesn't occlude.
Yes, exactly. You could cut the coping and have it completely hollow, and just put the coping where the abutment portion is. But I don't think in this type of patients it gives you any advantage. If you have gum covering the margin, you can trim it 4 months post-op. Yes?
Being oval, how could you screw it in if the distance between the adjacent teeth is too narrow?
Yes. This is a press fit implant. I didn't remember to tell you. This is the only implant that we put in by tapping, by impacts. It does not go in by screwing in. All the other implants, you use a wrench. This one you do by tapping in. So you do the drilling sequence, you do the countersinking, and when you put the implant into the socket, you don't go and get the wrench or the motor. You just use an instrument with a big plastic tip. So when you do the impacts, you are not creating damage on the abutment. And the threads are only for stability purpose. So when the implant gets in contact with bone, it uses those structures to get stability. For 4 months post-op, if we have gum covering the implant, you can use the coping, you can use retraction cord because it's not a delicate area, and you can use electrosurge or laser to have access to the implant shoulder. And this is the finished crown. It's full contour zirconia crown with just little amount of chipping. And again, if he has chipping, it will look like this. So he will not even know if that is the implant or the tooth. And on the molar implant, we have full contour without even porcelain. So you can see the very thin layer of porcelain up here, and the more posterior, the more full contour we go. Yes?
I've been doing the CeraRoot for years now, and I think my voice carries. I do the non-functional medium regionalization technique in the aesthetic zone on this particular implant all the time. It's beautiful with it. You just have to make sure that everything's out of occlusion, excursive movements, but otherwise I have great success with putting provisionals on at the same time and maintaining free gingival margins and the papilla. So, but it is technique sensitive.
Exactly.
You have to be careful with it.
Yeah.
But it can be done.
Yeah.
I mean,
This is the protocol that we do, but the more experienced you are, I agree with you, and the more you have restored titanium implants and you have cemented and you have seen what happens when you cement subgingivally.
Well, I've got several articles published on this particular technique. Anyway.
Exactly.
And so, but it's a technique-sensitive procedure, but it can be done with this implant, which is perfect for this particular, or your implant design is beautiful for that.
Yeah. The only thing is that when you place a crown and one day you have a longer gum, recession on the implant, and you did a crown, you cannot go back. So the difference is that when you do this all the time, you always know that the gum went as apical, as more incisal as possible, and we tend to have less interventions of soft tissue augmentation 4 months, 5 months after, because we let the gum go on its own. So the advantage of doing this is...
I see what your advantage is as well, but there's some question as to whether or not you can do it.
Yeah.
But you can do it, but it is technique sensitive.
Exactly.
And you have to make sure that you get your free gingival margin in position with your scalp of the platform of the implant.
Plus the temporary has to be exquisite. If it's done in 3 minutes and you go like this, and when you take out it's indented because it doesn't have a good fitting, that's horrible. Make sure that you use the analog and finish it off on the analog. Correct. Question?
Yes. I guess the point is also...
Can you put the microphone on?
Can you hear me?
Yes.
Yeah. So I guess the point is also is that in the real world, most patients in the aesthetic zone are not going to want to leave without something on there that looks like a tooth.
Yes. But if they tell me 5 times, doctor, people will not know I have an implant here, right? And they ask me this. I tell them, if it's my way, probably not. If it's your way, meaning if you tell me to put the crown, don't ask me if you have a longer crown on the implant. So when they always follow our protocol and we end up having a longer gum on the implant, it's our fault if we didn't put temporary crown. But we have seen that gum doesn't grow as much when we put temporaries. And it's true that some patients don't want Essex. It's not US, it's everywhere. People cannot go sometimes with Essex if they have meetings or they have photography sessions. But it's important to put you in place that 4 months after, if there is a complaint, aesthetic complaint, you have to have the protocol in a way so that you did everything that is successful. and when you put a crown, you have less soft tissue creeping, always. The more thin the periodontal tissue is, the more risky is that you end up having recession. CeraRoot 16 is the implant designed for molars. It's both the molar and the premolar is the implant that it's mostly used, especially because people are missing more posterior sides. So we have an area that has been healed, and when we have this type of ridge, and the keratinized tissue goes to the mid-crest, so we can see 4 millimeters below the CEJ here, and then it goes to the mid-crest. We never do a punch. This area here, we will position it buccally. So the type of incision that we do is this. The keratinized tissue goes all the way up to here. So if we do a punch, we end up with no precious gum. This is the most important gum for the implant. So that's the incision that we do. We don't need to do. We don't need to go inside the sulcus. We can do papilla preservation. The advantage of leaving 1 millimeter or more is that you know the gum level of the implant on placement. These are the countersinks that we use. So this is bone level, this is gum level, and this is the threaded portion of the implant, and this is the transgingival portion of the implant. The same with the ceramic ones. The ceramic ones have a thin laser line that is telling us where the last coronal thread of the implant is, and the thick line is telling where the shoulder of the implant is. So the deeper we put this countersink into the bone, the deeper the implant will go. I'm sorry. So this is an explanation to show you in thick biotypes how the osteotomy looks like. It's not always this type of thickness, so it doesn't mean that thick biotypes you have to stop your countersink at this level. It's just that this is a design made for the countersink, and for thick biotypes and for thin biotypes. So for thin biotypes, we put the countersink deeper into the bone, so part of the bone is in contact with the transgingival portion, so we don't end up having too much shoulder of implant coming out through the gum. And this is the same case that we were seeing before. I don't know if on the projector you can see, but the gum line on the medial is at the shoulder level, and on the distal it's almost 1 millimeter supra-gingival. So because it's a posterior side, we don't need to screw the implant deeper. Every time we do CeraRoot, we drill always 2 millimeters deeper than the implant length. So if you have to put a 10 millimeter implant, you should drill to 12. The advantage of drilling 2 millimeters deeper is that you can keep screwing down the implant until you like the final position. If you only drill 12, the last coronal thread will stop at the crest level. So the implant will not go deeper. So as much as you can, try to drill 2 millimeters deeper than the implant length. And 15 days post-op, the patient comes with gum, completely not mobile, but it's not mature. But I want to remind you that this gum was all the way here, and we did not do punch. If we do punch, we would have the crest going to the lingual as it was before. And just by doing this without bone graft, you will see what huge difference it makes on the emergence profile of the tooth. So look at the amount of keratinized tissue now that we have 4 months post-op. The implant is completely supragingival. And the impression coping, this is extremely easy to take impressions or do intraoral scanner. So this is the coping, finished coping, placed in place just to show you how the coping looks like. But you cannot build up conventional porcelain that much because you will have a fracture. So if you use this coping, this type of situation is perfect. You can build up porcelain on this type of situation. But if you have this type of situation, that's not ideal. So if you have this type of coping, you have to do an overpressed Emax crown. Do not build up porcelain. And if you use full contour zirconia, of course this coping is no longer needed because the crown will have a complete different shape. So because the implant was a little bit inclined to the mesial, this contact point is much more different to this. But when the implant is placed straight, many times you have this touching the premolar, this touching the second molar. And this is how the crown is left. We never, in posterior sides, we never prep the implant. We like it to keep it simple, plus we like it to keep the implant strong. We know that if we don't modify at all the implant, in 20 years' time, for sure, they will still be in the mouth. The more we grind them, the more difficult is to know what type of modification we do on the implant. So, before, after, and just by placing the gum on the facial. So, when you put the gum on the facial, you don't have to suture the gum to the lingual, because when you suture the gum to the lingual, the gum goes too much to the mid-crest. You have to suture mesial and distal. So, when patients come into our office and we explain them, this is conventional and this is one-piece zirconia. If you do this and you are lucky means normal population, this crown will not ever move. But if the mechanics and the tolerances of the implants are not perfect, you will have to come every now and then to screw the crown. And I'm sorry, but when we unscrew this, you will have to take some disinfectant because you will smell strong smell, and always. And we cannot compare using a big wide implant in molar areas to a narrow situation. So every time we have a big ridge, we like to use implants similar to natural dentition. And this is a diagram that we always like to use. Many times, cemented restorations, of course, in titanium implants have not just one gap, but two gaps. So this gap, if this is metal, this gap is all the way down in order to avoid showing through. Our implants are most of the times supragingival, the more posterior they are. In anterior zone, this is, with titanium implants, this is almost forbidden because we know that papilla will not stay in most of the times because there has to be a biologic space created in between two implants. So over the years it has been seen that sometimes it's much better to have a bridge between two natural teeth when there is not so much bone, instead of placing two adjacent titanium implants. But when we have zirconia implants, the story is completely different. So with zirconia implants that are restored gum level, not subgingival, with zirconia implants you have papilla preservation. There is no biologic space and there is no bone resorption in between two implants, no matter how close the implants are one to the other. immediate extractions. When the implant is so big and we have a lesion that we can clean, that would, and we have plenty of room to the nerve. If this comes clean and buccal and lingual is preserved, we go ahead and create the surgery the same day. Normally, we try to make the osteotomy in the middle of the septum, and at some point, the drill ends up using part of one of the sockets. It's much more easy if you start with a distal socket, depending on how close the roots are to the tooth. So it's much more easy to start here and then to go to the middle of the root socket. And this is day of cementation of the crown. And this is 4 or 5 months post-op. Full contour zirconia crown. I'm going to show you the technique step by step for the premolar. We extract this tooth. This patient did not want any type of root canal or reconstruction on the tooth, so we go ahead and extract it. And like I said before, we drill 2 millimeters deeper than the bone level, not gum level. So if the implant, if we want to place a 12 millimeter implant, we measure 14 millimeters from this interproximal bone down. So we go ahead and do all the drill sequence. It's initial drill. This is 2.3 drill. This is 2.8 drill, and then we use the 3.5. It's not shown here, but we use the 3.5. And after the 3.5, we go in with the countersink. When the socket is big enough, and we put the countersink in, sometimes we don't drill. So if the countersink is telling us that the margin of the implant is already at the gum level, we don't make the socket bigger, because if we make the socket bigger, we don't have stability and the implant goes in. So when we do an extraction, sometimes we don't even put the countersink into the handpiece. We have it, we take it with the fingers, we place it into the socket, and if it's stable, we go ahead and open the implant. This is how it comes. We unscrew from the sterilization blister, and we bring the implant into the socket, not by screwing in, but by pushing in, because this is a press fit implant. So we push as much as we can with our fingers, and then we remove that silicone tube, and we start to tap gently. The first tapping is the same type of tapping that you would do to inspect a vitality of a tooth. So you go gently, and if the implant doesn't go deep, you increase the tapping, and it starts to go down, and you stop where the shoulder of the implant is more or less 1 millimeter subgingival on the interproximal area. So we don't want to go deeper. It's a posterior side, so if the implant is exposed and the patient doesn't want a zirconia showing, we prep. And this is day of surgery. On the mesial, it's more deep, and on the distal, we can see completely the margin. Look at the distance available in normal dentition. This is normal dentition. There is no recession, so most of the times, if you put the implant to gum level, you have this type of situation. If the antagonist is extruded and you don't have too much room, you can tap a little bit deeper, but not too much, because you don't want the margin of the implant much deeper. So sometimes it's much better to reduce a little bit the opposing teeth if there has been an extrusion. Again, when the tissues, we think that they will be stable, we can use a coping, and on the day of surgery we can take impressions. We if we have impressions, it doesn't mean we have to do the crown the same day. We can have the impressions done, but do not start doing the crown until we see the patient. So it avoids us to put anesthesia just for the impression technique. So sometimes the coping doesn't fit because of the shape of the coping, and we just take out the coping from the mouth and we start prepping the coping until the coping sits. So because it's made of zirconia, if it's a contact point made of zirconia, it's even much better than if it's porcelain. So this is the type of situation, day of surgery. If the coping doesn't fit because there's no space occlusally, we prep the shape of the coping until we have enough space for the porcelain. This is a situation when we send it to the lab. They have this coping into the impression tray, and then in the coping, the lab cements the lab analog, so they cement it. It's important that they cement it because if it's when they vibrate the stone model, the analog can move, so they have to cement the analog with the coping, and then they can do any type of crown after they have this coping in the mouth. They can do any type of crown. You can scan this, you can do IMAX, you can do any type of crown. The coping that was used here, you can re-sterilize it and use it again for another patient. But we decided to use this coping for this patient because it was almost ideal situation. Again, we have different lab analogs and different implants, and most of the times, because we don't have to prep the implant, the shape of the coping has exactly the same shape as the implant. Different colors, occlusal space plenty, and this is the final crown made. I don't remember if this is porcelain or IMAX overpressed. Maybe I think it's IMAX overpressed on top of the coping, and the patient comes back 4 months post-op with identical situation as the implant placement. So we do period test every month or every time the patient comes, and if the values are negative 4 months after, we go ahead and put the crown. If this is not a strong period test value, we tell the patient to wait 1 or 2 more months. 4 months post-op, when we have a gum that is covering the margin, we put sometimes anesthesia, so the coping can be completely seated to its final position. And it's extremely important to clean well the excess of cement, so use all the superfloss and all the devices you have to go subgingivally and access any cement that might have stayed inside the gum. So 4 months post-op and final situation. Other impression techniques. We have seen impressions with the coping, but extremely simple cases like this, that the implant is almost visible. Yes, a small soft cord, retraction cord, can be used with not too much force, and it goes perfect, and you can scan or take impressions conventionally even without coping, because if the lab receives an impression with this type of situation, they don't even have to know that this is an implant. You can just tell them this is a tooth, put an impress on top of this abutment that I have prepped. I'm a very well restorative dentist, and I have prepped this tooth amazing. So conventional direct impressions without coping. iTero, this is the future. For some doctors is the present, but this is amazing. And if you have access to the implant, you take impressions with no errors, because you see, you do the crown with what you see. And I'm going to give you this example. This is a one-piece implant, as you have seen, but the design of the implant, it's made because sometimes the implant is placed more lingually and sometimes it's placed more buccally, so we don't need a huge abutment for the big size of the implant. And by this I mean that when you take an impression and you scan this type of situation, here we have full visibility of the shoulder, which is more or less 1 millimeter thickness, but here we don't have visibility of the margin. So interproximally, we never put an electrosurge or laser if we see shoulder. So the crown doesn't go all the way to the margin. The crown stays almost halfway into the margin. So the more space we give to the gum, the more healthy the papillae is. So just by having this amount of shoulder doesn't mean that your crown has to have the same thickness. You can do what we call platform switching. We can do the crowns narrower. We cannot do the crowns bigger, but we can do them narrower, and no problem. The amount of strength of areas, 0.5 millimeter in zirconia, nowadays for us is not any contraindication. And of course, it's not 0.5 millimeter all the way. It's 0.5 millimeter in certain locations, which is not an issue. CEREC, people that have CEREC and they have to scan supragingival implants, look at what they see on their screen. It cannot get more easy to scan a supragingival implant. So don't be afraid in posterior sides of leaving implants supragingival. Patients don't complain about white necks of teeth. Patients complain of yellow root natural teeth. So with CEREC, of course, you design nowadays not just the shape, but you also design what type of color, and not even that, you can also tell, depending on the block, you can have a block with different tonality, so it can be more yellow on the base and more incisal to the top of the occlusal surface. So it's amazing with CEREC what you can do. Is it time to how do we modify the margin of the implant? This is an implant placed in a healed site. There's a little bit of root, and this shoulder is 2 millimeters supracrestal. We don't want to go deeper, because in some areas we will be subgingival if we go deeper. So this is the way we suture. The gum covers the margin of the implant, and look at the gum of the neighboring teeth. We have to predict that this gum line will be in line with the natural teeth. So the patient comes 4 months post-op, and even if the implant has become yellow, stains, any type of wine or tea, or sometimes chlorhexidine, leave the implant. In this situation, it turns dark. If we don't want to have this margin exposed, we prep the margin. But we don't prep the margin. We don't prep the margin with the same inclination. What we do is we bevel this corner, and this is the type of burst that we must use. So even if you know that you go more fast using this, don't use rough bursts. To use this type of burst that will create much less damage. It's going to take more time, but it's going to be much more friendly for the structure. This is called fine or ultra-fine diamond. And you just prep all the way down to the margin. Because we make a new modification, we cannot use lab analog. So conventional crown and bridge impressions. And the patient comes for the final crown. And this is the new shape on the facial. Completely normal on the lingual because it's not a problem. And this is day of placement. This is how another case. We have an implant margin that we have to prep. And this is how the tooth looks like. And one fast case more. The patient has to have extractions of teeth with apical lesions. So that's what we do, and we will only leave 2 teeth without any lesion. And also it's very good for proprioception, so we know that the patient will not bite more strong than with his teeth. And the margins of the implant are not deeper than 1 millimeter, and we don't want to go deeper because if we have something exposed, we will prep the margin. So we screw the implants almost until there is a stop, and we prep this tooth. And we make one piece bridge on top of the implants, splinting teeth and implants. Rigid, it has to be thick. This cannot fracture. If this fractures, we have a different loading and in different zones, and one's implants will have more load than other implants. So on the lingual, make sure it's a thick material. Don't make the teeth on the lingual or palatal to have tooth shape. Make a thick structure. Patients will complain, but if this breaks, then you are in trouble depending on the stability of your implants. 3 months post-op, the only implant that we have exposed margin is a canine, but the rest of the implants are gum line. So immediate placement, 1 millimeter subgingival, and we don't have recession. This is 4 months post-op. And we do a little bit more prepping on the teeth, so we end up, but we decide not to prep any implant. So even if there is an exposed margin, we decide to do conventional impression technique using the copings. We have more than 1 millimeter supragingival implant here. It's posterior side. Patient will probably not even detect it. And because all the margins are supragingival or gum level, the copings stay on the implants very easy. And we take pick-up impression, and on the lab we have lab analogs because we didn't do any prepping on the implants, so we can use the same analogs. And we design a new shape. This is going to be a bridge, single implant, tooth, implant, bridge. We don't have the need to go teeth by teeth. We can do bridges in the front area. So full contour zirconia on the palatal, just incisal edge and buccal porcelain. This is day of cementation, 4.5 months after the surgery, and we have left enough space for the papillas to fill the gaps. And we can see the margin of the implant, but I can tell you that this is never a complaint. So don't be afraid of leaving zirconia implants exposed. And the same on the posterior. And 2.5 years post-op, this is what we have. We have implant, tooth, implant. So look at the amazing scallopness and how well, and the tissue with no inflammation at all. This is the margin of the implant, 1 millimeter supragingival. And when we look at the other side, we have tooth, implant, pontic, and implant. Before, after. This is right after the surgery, without prepping the teeth, and this is a horrible X-ray of implant bridges, and then this is the other 2.5 years post-op. Projector is not very well, but bone, it's very well maintained. And very fast, 8 years of follow-up. Let me show you some extreme cases. What we have. Look at this.
Xavi, I hate to do this to you, but we're really running over.
Okay.
It's this me, and then this. We have to kind of follow a schedule here.
One more case and that's it.
Please.
So, look at this case. We have a root. We have to extract these teeth. Implant placement, and then this is the situation. We have a supragingival implant, 2006, and the patient, this is occlusally, and the patient comes back 2013, 7 years after, without posterior teeth, extruded teeth, and look at the papilla between, this is day of cementation, look at the papilla on day of crown delivery, and look, 2013, 7 years post-op, we have, of course, more implant exposed, just the same way as canines has had more recession, but the bone level is completely preserved, even in horrible cleaning hygiene. So, lucky for us, many times patients have decays, but patients with decays normally do not have periodontal disease, and this is the situation. So, extremely stable, even in very difficult technique. And yeah, so thank you very much.